Behavioral health and education often centers on the student who is isolated, frustrated, and labeled as the primary obstacle to a functioning classroom. Oppositional Defiant Disorder, or ODD, is a real clinical diagnosis backed by psychiatric research. Looking at a typical student population, the clinical prevalence of true ODD is statistically limited to between 3 and 16% of school-age children. In practice, however, the ODD label is frequently applied to a much larger group, extending far beyond the actual clinical cluster. This occurs because defiance often serves as an administrative shorthand for any disruptive behavior that an educator or administrator struggles to manage. Relying on this diagnostic misattribution obscures the specific clinical realities that the student is actually facing. Improving these outcomes require diagnostic recalibration, ruling out other disorders, and adult-mediated interventions. Without this precision, schools commit resources to punishing surface-level symptoms while the underlying causes remain untreated. A clinician must verify that a student clears a high diagnostic bar before an ODD label can be applied. The first requirement is temporal. The pattern of irritable or defiant behavior must be locked in for at least 6 months. Behavioral issues that are fleeting or appear only as a reaction to temporary life stressors do not meet this clinical standard. There is also a requirement for symptom density. At least 4 distinct clinical behaviors must be present and frequent. These behaviors include losing one's temper, arguing with authority, actively defying rules, or demonstrating deliberate vindictiveness. Critically, these behaviors must be observed in interactions with people other than the child's siblings. The symptoms must also result in significant functional impairment at home, at school, or within their peer group. ODD represents a chronic clinical threshold rather than a description of a student having a difficult semester. The primary point of failure in behavioral management is the skipping of differential diagnosis. This logic gate filters out conditions requiring different treatments. Unmedicated ADHD mimics defiance through poor impulse control. Anxiety disorders trigger fight or flight responses when overwhelmed. Trauma manifests as structural defiance for survival. Lastly, processing and language deficits cause frustration, indistinguishable from insubordination. Each of these diverted categories requires a specific and distinct clinical modality. Treating trauma or anxiety with discipline intended for defiance escalates the problem and ignores the actual source of the behavior. Most school systems respond to defiant behavior with a reflex toward punitive discipline. Clinical evidence shows that punishment-based interventions are ineffective for ODD, as they almost always lead to further escalation. The most effective interventions for ODD move the primary focus away from the child. The gold standard for treatment involves parent management training and parent-child interaction therapy. Parent management training, or PMT, coaches the adults, both parents and educators, in precise techniques for managing behavior and reinforcing positive outcomes. Parent-child interaction therapy, or PCIT, focuses heavily on rebuilding the relational bond that the defiant behavior has strained. Managing true ODD requires a focus on adult management and environmental engineering. Implementing this level of differential diagnosis and specialized coaching requires a clinical infrastructure that most schools are not equipped to provide. The MentalSpace school model addresses this by integrating dedicated therapist teams and crisis intervention into daily operations. Same-day teletherapy ensures immediate professional support during a crisis. Family counseling provides the environment needed for parent management training and parent-child interaction therapy. The model eliminates financial barriers by accepting major commercial insurance and providing services at no cost for Medicaid recipients. This architecture manages compliance with federal privacy laws and Georgia's House Bill 268, which mandates mental health support integration by July 2026. Clinical theories only work when they are supported by a delivery mechanism that is accessible, compliant, and integrated into the school environment. When schools replace punitive measures with these integrated diagnostic and support protocols, the results are measurable. Schools utilizing this clinical architecture have seen an 89% improvement in student attendance and a 92% reduction in anxiety. The attendance gain is a direct outcome of moving away from the suspensions that typically follow a defiance label. The drop in anxiety indicates that the underlying conditions previously masked as ODD are finally being identified and treated. Integrated mental health care now serves as the foundational requirement for long-term student success and overall school health. A school's behavioral landscape stabilizes when leadership changes the question from, "How do we punish this defiance?" to, "What